So we are here to discuss a case where the data from the Checkmate 274 trial might be quite relevant. So this is a high-risk muscle-invasive bladder cancer patient, clinical T3B-N0 disease, who received neoadjuvant cisplatin-based combination chemotherapy and underwent radical cystectomy. And the pathologic stage was PT3N0 disease. The tumor is PD-L1 high, and the ECOG performance status of the patient is 1. So at this point, Andrew, I'm going to ask you how you would treat this patient now, just based on the science, knowing that this Checkmate 274 trial has not led to any regulatory approvals. Just based on the science, how would you treat this patient now?
Well, I suppose there's two parts to that. And I suppose first, I like to just discuss the standard of care as what we do at the moment and then ask some questions perhaps. We know the patient's at a high risk of recurrence because we see residual disease in the cystectomy specimen. And I would estimate the risk of recurrence in this patient to be more than 50%. So this has clearly been an area of need for our patients. And the standard of care for some time has been surveillance. But I do like to think about what some of the other potential approaches might be. And I've never seen this used, but one could see if there was a role for additional chemotherapy. And I have seen some retrospective series which approached this question and suggested there may be a prolonged time to recurrence, but have never seen it in practice. Is this something that you've ever used or see a role potentially in this patient at all?
A good question, Andrew. So we don't have any prospective data, but as you pointed out, there is a retrospective study from the NCDB database that did suggest that adjuvant chemo in patients with high-risk disease following neoadjuvant chemotherapy might enjoy a benefit. However, there were many problems with this retrospective study, as there are with any retrospective study, which is there are many patient selection factors that make someone opt for adjuvant chemotherapy in patients like this. And this could not be well controlled for in a large data set like the NCDB data set. Also, the specific chemotherapy drugs given were unclear. So suffice it to say that at this point in time, following neoadjuvant chemo in high-risk patients with residual muscle-invasive disease, we don't have any high-level data for administering more adjuvant chemotherapy.
Thank you for outlining that. I'm very curious as to the role of immunotherapy, and we have seen multiple trials investigating this approach in the adjuvant setting. We did see the first analysis for Checkmate 274 reported ASCO GU this year, and in brief, this examined the role for adjuvant nivolumab compared to placebo in a population of patients at high risk for recurrence post-cystectomy. I believe our patient would fit the inclusion criteria for this trial. He's a fit patient, he's got no contraindication to immunotherapy, and he's got residual disease at cystectomy following chemotherapy. And the data seem to favour nivolumab in this setting and potentially enriched in the biomarker positive population. Do you feel that this might be an appropriate treatment for our patient?
I think so, Andrew. I was really encouraged by data from the Checkmate 274 trial, which of course was a randomized phase 3 trial comparing adjuvant nivolumab versus placebo. It was placebo controlled. So really we have more confidence in the disease-free survival primary endpoint. And there were two co-primary endpoints of disease-free survival in the intention to treat all-comer population, as well as the disease-free survival in PD-L1 high population. And suffice it to say that the co-primary endpoints were both met with a hazard ratio of 0.70, which was significant in the intention to treat population, and the hazard ratio of 0.53 for disease-free survival in the PD-L1 high population. So the co-primary endpoints have been met. The secondary endpoints, of course, are not powered for usually. Survival was not presented, but there were other secondary endpoints that were met, which was the non-urothelial tract recurrence-free survival, as well as metastasis-free survival. So I'm really encouraged by this study. I expect a disease-free survival benefit seen with an adjuvant immune checkpoint inhibitor to translate also to improved overall survival, given that the benefits from these agents are highly durable. We know that in the adjuvant or neoadjuvant chemotherapy setting, disease-free survival at the individual patient level does correlate with overall survival. What we don't know is how much improvement at the trial level correlates with improvement to survival at the trial level. That's what we don't know. Again, I'm optimistic based on the Checkmate 274 trial, so I'm looking out for survival data, but I think these are potentially practice changing.
I did have one other question, and I'd value your thoughts about atezolizumab, which is a PD-L1 inhibitor. This has also been studied in the adjuvant setting in a large phase 3 clinical trial. But in contrast to what we're seeing with the Checkmate 274 results, they were less compelling. Disease-free survival and overall survival were not significant. And the biomarker for PD-L1 didn't seem to discriminate efficacy between, in terms of the efficacy of the agent. Given the similar populations of patients that are recruited, do you have a sense for why they might have shown discordant outcome?
That's a good question, Andrew. We are all wondering why the IMvigor010 trial was negative, which of course was a non-placebo control, no placebo in this trial, comparing atezolizumab versus observation in the adjuvant setting was very similar otherwise, a similar patient population, where disease-free survival in all comers and overall survival in all comers was not met. And also when they looked at the PD-L1 high population, the endpoints were not met, and that was a secondary endpoint looking at the PD-L1 high population in this study. So it is somewhat surprising and confusing why one trial was positive and one is negative. I think we don't know the answers to this. The easy answer to that is maybe it's the PD-1 inhibitor versus PD-L1 inhibitor issue. Well, if the third ongoing trial now, which is evaluating pembrolizumab, the ambassador trial is positive, that will give us an answer there. So maybe it's PD-1 versus PD-L1. The second point is that the placebo control was only there in the Checkmate 274 trial. Does that make a difference? I tend to believe no, it does not, because the difference was so huge that I really find it hard to believe that the absence of placebo in IMvigor010 could make such a huge difference in detecting tumor recurrence. So overall, it's a mystery. I think that the third trial, the pembrolizumab ambassador phase 3 trial, which has co-primary endpoints of DFS and OS in all comers, would, I think, help us there.
Thank you. One final thought is that if this were to gain regulatory approval, is the biomarker going to be specific in terms of the PD-L1 assay to nivolumab in this setting? So would my institution have to use a specific biomarker stain for that?
Ideally, yes, because I don't know how the biomarker used for PD-L1 in one study translates to the other. Especially, we know that the biomarker used in the atezolizumab studies, which of course stain the immune cells, and the biomarker used in the nivolumab studies stain the tumor cells. So it's really the difference there is quite clear. And I would be nervous using a different PD-L1 assay when using nivolumab, for instance, if nivolumab got approved based on the Checkmate 274 data. So I would really want to be biomarker specific as much as possible here.
So looping back to the patient, I think the standard of care has been surveillance for some time, but it sounds as though the data on nivolumab has been very promising. And certainly this is a space to potentially watch, because we may see an accessible additional option for our patients in the near future. Do you think that's a fair comment?
That's a fair comment. I think at this point I could mention the circulating tumor DNA, ctDNA data for IMvigor010, which as we just discussed, the IMvigor010 trial was negative for disease-free survival in all comers, one of the primary endpoints. But when they looked at patients who had post-operative ctDNA positive for minimal residual disease, and this was ctDNA in blood, of course, with tumor information, so tumor genomic profiling information guided ctDNA profiling using the Natera platform, was indeed very promising in this unplanned retrospective study, in which patients who had ctDNA positive disease did have benefit from adjuvant atezolizumab, while ctDNA negative patients did not. One of the cons of this study was even in patients who were ctDNA negative, 30% of patients did recur. So the fact is that ctDNA might be better than nothing, but it's not clearly perfect. So I think that we need some kind of biomarker to select patients optimally for patients who have microscopic disease that might benefit from adjuvant agents, and potentially these data need to be applied and evaluated and validated in the Checkmate 274 trial, as well as the ongoing, potentially sometimes soon completed Ambassador Adjuvant pembrolizumab trial.
Sounds like there's some exciting times ahead for selecting therapies in bladder cancer. So it seems to be a good area and some nice advances for patients that we're seeing.